طبعا هكون يعني في حضور الدكتور عادل رفعت يعني رئيس الوحدة بتاعتي
حبيبي.
طبعا وإن شاء الله كده يكون يعني الويبينار مفيد للكل. وطبعا برحب بالدكتور عبد الله من انجلترا يعني، ودايما كده ان شاء الله في احسن حال وتفوق دائما. فنستأذنكم هنبتدي اول توك. انا اوريدي 8 minutes late يعني، واول توك هتكون للدكتور عبد الله وهتكون عنوانها عن النيو alignment options in total knee replacement. اتفضل دكتور عبد الله.
ميرسي جدا محمد، وميرسي جدا دكتور عادل رفعت برضو المجهود ده واضافتنا، واللي احنا نشرف لينا نكون موجودين النهارده في الساينتفك ميتنج ومع اساتذتي كلهم في اسكندريه.
حبيبي عبد الله.
انا هشير السكرين اهو على طول. تمام. تمام. فالبرزنتيشن الاولانيه new alignment options in total knee replacement. انا currently senior knee fellow at Oxford University Hospitals. No disclosures relevant to the topic today. Total knee arthroplasty is an effective method for treatment of severe osteoarthritis of the knee and providing pain relief and improving function in majority of patients with degenerative joint disease. However, dissatisfaction from
عملت شير السكرين.
انا عملت شير السكرين. هل هي طالعه لحضرتك؟
ممكن حضرتك تعمل شير سكرين من السهم الاخضر وتفتح الباوربوينت وتختارها.
تمام. انا عملت كده اكشلي. ثانيه واحده. ديسكتوب. ايوه كده تمام.
تمام. بعد اذن حضرتك فول سكرين بقى للباوربوينت.
تمام كده تمام.
تمام حضرتك اتفضل.
تمام. يبقى new alignment options in total knee replacement. I'm currently a senior knee fellow at the hospitals. Sorry الإعادة. No disclosure relevant to this topic. Total knee arthroplasty is an effective method for treatment of severe osteoarthritis of the knee and providing pain relief and improving function in majority of patients, as we all know. However, dissatisfaction following total knee arthroplasty is well documented phenomenon. As reported by Nunley et al., only 66% of TKR patients report their knee to feel normal versus 87% following total hip replacement. Many factors for patient dissatisfaction have been implicated, including modifiable and non-modifiable patient factors. However, in an attempt to improve patient outcomes and function, several specific design modifications and alignment strategies have been implemented. So these are the traditional technical goals of total knee arthroplasty, which included restoring the neutral mechanical alignment of the limb, restoring the joint line, achieving balanced ligaments and gaps, and normal Q angle and patellar tracking. But actually, is mechanical alignment the only alignment option in total knee arthroplasty? And does it affect the normal knee kinematics and joint line obliquity? Then what is kinematic alignment? Do we need computer-assisted technology and robotics to do it? Any evidence from the literature supporting it? And lastly, what is restricted kinematic alignment, adjusted mechanical alignment, and functional alignment? So the alignment options we have for total knee replacement include anatomic alignment, which is historical and currently obsolete, but I'll discuss this in a second. The two other options are mechanical alignment and kinematic alignment. The ones in blue are actually the popular ones. Mechanical alignment has been popular for years. Kinematic alignment is gaining popularity in the last couple of years. The ones in red are actually modification of the ones in blue, included the adjusted mechanical alignment, the restricted kinematic alignment, and lastly, the functional alignment. So the anatomic alignment, which I just mentioned is obsolete, was initially described by Hangford and Krokow in 1985, as per the reference at the bottom of the slide. So they wanted to recreate the obliquity of the joint line by altering the surgical target in the coronal plane. So by measured resection, they wanted to cut the tibia in 3 degrees of varus and the vulgus and the femur in 3 degrees of vulgus, and the posterior, and aligning the femoral component, to the posterior condylar axis, and not in 3 degrees of external rotation as we do with the mechanical alignment. This concept was criticized. They had a lot of technical problems and became obsolete. But however, this concept can still be viewed as a precursor to the kinematic alignment. This is the paper in 1985 describing the anatomical alignment, and you can see on the right side the tibial component is in 3 degrees of varus. And actually, I found that this recreates a more physiological gait, as this tibial tray will be parallel to the ground in a single stance phase of gait. With regards to mechanical alignment, which we all know is these are the principles of the classical mechanical alignment, which I'll explain in the next couple of slides. I'll go quickly through these. So aligning the femoral component perpendicular to the mechanical axis, and we know the valgus cut angle, which is measured with the difference between the anatomical and mechanical alignment of the femur. And then it can differ depending on the height of the patient, and also aligning the tibial component perpendicular to the mechanical axis. We always put the femoral component at an external rotation of about 3 degrees, unless we had a hypoplastic lateral femoral condyle, it could be even more than 3 degrees. And this is mainly because we're cutting the tibia in 0 degrees hip-knee angle instead of 3 degrees of varus. And to compensate for this, we need to external rotate 3 degrees to have a rectangular gap. And lastly is the release of ligaments, which when there is a systematic way of releasing the ligaments, whether it's varus knee, valgus knee, and in a fixed flexion deformity, for example, one of the options was increasing distal femoral resection by about 1 to 2 millimeters to help with a fixed flexion deformity. But actually that is quite debatable now with the kinematic alignment because it affects the joint line. So it is debatable whether this actually mechanical alignment can affect the normal native knee anatomy and affect the kinematics of the knee, because traditionally, anatomically, the tibial varus is around 3 degrees and the valgus in the femur is around 3 degrees of valgus. And there is a wide variation in limb alignment, and Bellman's et al. Showed that 30% of the male non-arthritic patients will have a varus deformity of 3 degrees. So with the mechanical alignment, we know that we try to align the component to 0 degrees hip-knee angle, which can change the obliquity and raise the joint line from normal. And as a compensatory mechanism, we need to externally rotate the femoral component to 3 degrees. These all can theoretically alter the patellofemoral and tibiofemoral kinematics, which can cause pain, instability, and loss of motion. And then that was when the kinematic alignment started gaining popularity and was first explained by Howell et al. As a technique to seek to recreate the anatomy of the native knee. The definition of it is actually co-aligning the axis and joint lines of the components with the free axis and joint lines of the pre-arthritic or native knee without any ligament release or minimal ligament release. This is a picture and figure taken from Personalized Hip and Knee Joint Replacement book, chapter 16, and it explains these three axes that we would like to co-align with the native knee. The purple one is where the patella flexes and extends on the femur. The green one is where the tibia flexes and extends on the femur. And lastly, the yellow longitudinal one, which is where the tibia rotates around the femur. So the three goals of kinematically aligned total knee arthroplasty are restoring the native articular surface, restoring the native knee and limb alignment, and restoring the native laxities of the knee. What are the theoretical and intended benefits? It's aiming at more physiological and more reproducible implantation, can improve the knee function, patient satisfaction, and possibly the component lifespan. These are the principles of kinematic alignment. I'll actually go through each of these in a separate slide. So first of all, it is about symmetrically resecting the femoral condyles and tibial plateaus having compensated for wear, which in other words means that we want to resurface the knee joint by removing cartilage and bone thickness equivalent to the implant thickness. So for example, that's a medacta. So you have a 9 millimeter distal implant thickness and 8 millimeter posterior thickness. So you want to cut exactly the same thickness of the implant. So for example, in a varus knee, which we'll take as an example, in the healthy lateral femoral condyle, you want to remove exactly the same as the distal implant thickness, which will be 9 millimeters for implant thickness, but we want to make sure that we consider that we have 1 millimeter lost with the saw blade curve. So 9 millimeter thickness minus 1 millimeter for the saw blade curve. This will keep an 8 millimeter thickness in a healthy lateral condyle. And the other thing we need to consider is we need to compensate for wear. So in the medial femoral condyle, where we lost at least around 2 millimeters based on MRI studies, we then will need to have a 6 millimeter thickness, which is 9 millimeters minus 1 for the saw blade curve and minus 2 for the wear at the medial femoral condyle. With regards to the posterior cut in a varus knee, we don't routinely have any wear, and so we expect to have 8 millimeters minus 1 millimeter from the saw blade curve. And we usually keep measuring these with a caliper to make sure that we have cut the right thickness. So these were the jigs used by Stephen Howell et al. In the United States, and he actually has these alignment guides for the femur, which has one end would have a worn end and an unworn end. With the worn part, you'll have a 2 millimeters spacer or block behind it to compensate for wear at the arthritic condyle. For example, in a varus knee, this will sit on the medial femoral condyle. And this is an oblique hole here so that you can move this around the intramedullary rod of the femur to sit nicely on the femur before you do the cut. So we're expecting the cut to be just parallel to this yellow line after compensating for wear. And with the slope, you try to mimic the patient's own slope by actually using an angel wing medially through the cutting jig and make sure it mimics the patient's own anatomical slope. With regards to the rotation, in comparison to the mechanical alignment, we use a 0 degrees external rotation, which is more anatomical. With regards to the rotation of the tibial tray, we usually use the medial third of the tibial tubercle with mechanical alignment, which is actually the same, but here, as explained by Dr. Howell, and he uses the lateral tibial plateau, draws a line through the midline of it, and then another parallel line within the middle of the knee, and that's usually to check and assess the rotation of the tibial tray. In kinematic alignment, it includes minimal soft tissue release. So for example, these jigs are offered by Medacta. If you have a varus, if you have a tight medial gap and you want to do more medial release, instead of releasing the MCL, this jig can allow you cut 1 to 2 degrees more varus. So this flat part sits on the tibial cut and then adds 2 millimeter of varus cut to the tibia. So theoretically, this has some risks, as this is a post-op X-ray of a kinematically aligned knee replacement, and it does show that the tibial component is in varus. So theoretically, we have a risk of long-term loosening. But however, Howell et al. Reported that at 10 years, he had no problems with good survivorship and no high revision rate in his cohort. And one explanation is that kinematic alignment restores the joint line to obliquity, which is parallel to the floor when standing, thereby reducing or avoiding overload of the medial and lateral tibial compartments. This is a figure from Personalized Hip and Joint Replacement book, page 331, and it does show the difference between both techniques. In the middle one, it is a kinematic aligned total knee replacement. Both are in the same patient, and you can see the tibial tray is in a little bit of varus. In the picture on the far right, this one, it's actually a mechanically aligned total knee replacement in the same patient, but in the contralateral leg. When you measure the angles preoperatively, the lateral distal femoral angle and the medial proximal tibial angle, it's actually same to those with the kinematically aligned knee replacement. And the take-home message from this figure is that the kinematic alignment knee replacement may be a more kinematic and more physiological way of knee replacement. This is the paper by Stephen Howell et al. Reporting 10 years results for kinematic aligned total knee replacements, and he had excellent survivorship and low revision rate with excellent level of function. This paper actually was not about kinematic alignment, it was about mechanical alignment, but the take-home message supports kinematic alignment technique in that 20-year results, they compared the functional outcome and the survivorship of patients who had a mechanically aligned knee and had a mechanical alignment within 3 degrees of hip-knee angle, to those who were outliers with malaligned knee replacements. And they concluded that neutral mechanical alignment provided, didn't find, sorry, that neutral mechanical alignment provided better implant survivorship. Another paper by Shelton et al. Measuring the forces in the medial and lateral compartments using instrumented tibial inserts intraoperatively. And they compared the forces in patients who had varus or valgus outliers with those who were within neutral alignment, and they didn't find higher forces in those who were outliers. The limitation of the study is it was non-weight bearing measurements and were done intraoperatively. Kinematic alignment then can be performed manually or the use of assisted technology, and that's one of the advantages of it. You can use measured resection manual instrumentation, you can use the navigation or personalized cutting guides. And recently, definitely the robotic system and technological assistant can be very useful, but you can still do it with measured resection manual instrumentation. Next is which implant designs can be used. The medial pivot is the most commonly used, but you can still use cruciate retaining or substituting designs. Now the companies are all marketing for the kinematic alignment jigs as one of the trending instruments in orthopedics knee replacement. The left is the Medacta knee, which I actually used, and the next one is Persona kinematically alignment knee that I haven't used, but I found online, and they have a surgical technique now for it. I'll skip this for time, and the video, so I'll skip this also because of time. So I explained these jigs used by Stephen Howell et al. To cut the femur, but Medacta also provided this jig, which I actually used, which is more modular, so you can use a spacer at the back of a worn condyle, and this sits on the femur, and you have a dialing here to just dial the valgus angle. You can have 0 to 12 degrees of valgus, and you dial it until it sits nicely on the femur, compensating for wear at the arthritic condyle, and then you do the distal cut. Here with this extramedullary jig, you cut the tibia and measure your resection from the base of the tibial spine medially and laterally, and you want 10 millimeters as explained and described by Dr. Howell in the States. However, recently this implant and this jig is under evaluation, will be hopefully available in after March, provided by Medacta, which I actually had an opportunity to use with Mr. Jackson and Prof. Price in Oxford, which actually 2 rods that could be joined to the lug drills of the femur after you resurface the femur. You have this jig then connected to the tibial resection guide, and these go onto the femur. So you use the femur as a reference to kinematically cut your tibia. And that's from the Twitter account of the Oxford Knee Group, explaining the advantages of using this jig. But with constitutional alignment, if someone have very big deformity, whether actually kinematic alignment will be good, we are not 100% sure, and that's because with very big deformities, you may put the implant in a big varus deformity, and we know the long-term survivor, as reported by Howell et al. Is good, but we're not sure if the deformity is very big, whether this is true or not, and we need longer-term results. With mechanical alignment in this big deformity, you may need a lot of soft tissue release, which is also can cause some problems. So here one came the hybrid techniques, which included the restricted kinematic alignment, which is one of the alignment options. You still follow the same principles, but limit your correction to 5 degrees of neutral in the femur and the tibia, and a total of 3 degrees. And this gives you the advantages of both. You still don't do a lot of ligament releases with mechanical alignment, and you still don't put the implant in a very big varus angle that could theoretically risk loosening on the long term. An interesting article here published in 2019 and by Charles Rivera et al. Titled "The End of an Era: Mechanical Alignment." Is this true? Well, we're not sure. I think we'll need to wait for long-term results, but it could be true. The adjusted mechanical alignment is similar to the mechanical alignment techniques, but with undercorrecting the deformity to minimize the number of and the amount, of soft tissue release needed. This paper supports this, shows that slight undercorrection can result in superior outcome. Patients with preoperative varus have had better clinical and functional outcome scores if the alignment was left in mild varus. And lastly, the functional alignment, and this interesting paper published by Usadik et al. And Professor Haddad in Imperial College in London. And they referred to this functional alignment as a hybrid technique. And it's mainly about robotics knee replacement, which Professor Mohamed will discuss in the next talk. And it adds precision, and at the same time, you can balance the soft tissues and make sure you, it's a more reproducible way of putting the implant in a non-neutral limb alignment. So lastly, to conclude, so mechanical alignment has been considered the gold standard for years. Still, the optimal alignment is debated. Promising results and evidence now available to support kinematic alignment. It's still a relatively new technique, and further work is needed to obtain more robust data on long-term survival. Restricted kinematic and adjusted mechanical alignments are options to consider with big deformities. And lastly, technologies that permit accurate reproduction of implant positioning and objective measurement of a soft tissue balance, such as robotic, may play an important role in improving our understanding of the optimum alignment strategy and implant position. Thank you. And sorry if I took more time.
Can you hear me like this?
Sorry?
Can you hear me?
I can hear you, yes.
We thank you very much, Dr. Abdallah, for this talk. And we have now a good number of participants. I think most of them will be hearing this concept of kinematic alignment for the first time. And this is really a very pretty much recent concept which Dr. Abdallah has raised. Okay. So, if there is any questions? My comment on this talk will be that this is a new concept. We have to treat it very carefully. You cannot hear me?
I can hear you, Professor Mohamed.
I think the people are will connect them. Can you hear me this better?
Yes.
Okay, so just as I've been telling that the kinematic alignment is a very pretty much new concept which Dr. Abdallah has raised, and most of our audience maybe is new for them this concept. Yeah, just to conclude or to summarize that this is a new concept. It is still under research. The kinematic alignment versus mechanical alignment. This is, I don't have another mic. This is the problem. So either you have this mic or without mic, which is better? This is the problem. So I don't know. You're managing with this mic or no, Dr. Adil? إيه الأخبار؟
وحش قوي وحش قوي يا محمد.
أشيله تاني؟ أشيله؟
جرب كده. انت بتتكلم الكمبيوتر ولا الموبايل؟
لا ده كمبيوتر. كده أحسن؟
دكتور حضرتك لو تقدر تدخل من على الموبايل هيبقى افضل، لان اللابتوب شكل فيه مشكله او حاجه.
الو دكتور محمد.
محمد حضرتك سامعنا كده؟
كده صوتي احسن يعني ولا راكب كده احسن؟ صوتي طيب من غير كده طبيعي اكتر.
دكتور لو حضرتك تقدر تخش من على الموبايل يبقى افضل.
لا اخش من على الموبايل، انا يعني هعمل لك شير سكرين ازاي من على الموبايل؟ انا ما عنديش التوك بتاعتي مش على الموبايل.
شير سكرين من على اللابتوب عادي، بس اتكلم من على الموبايل عادي.
اتكلم من على الموبايل يعني ادخل على زوم من على الموبايل؟
بالظبط يا دكتور.
احنا ممكن نعمل ميوت ونقفل الفيديو من عند اللابتوب خالص، وحضرتك تتكلم من على الموبايل، وندخل حضرتك الاكونت بتاع الموبايل على انه بانلست عادي.
يعني ممكن دكتور عادل يتيك اوفر لو في اي كويشنز لغايه لما اشغل من على الموبايل.
عبد الله.
ايوه حضرتك.
دكتور عبد الله معايا؟
ايوه انا مع حضرتك.
في احمد زهدي بيسأل هل الجيكس for kinematic alignment available now in Egypt or not؟
I'm not sure actually. حد كان سألني نفس السؤال، وانا سألت الراب اللي هو بتاع ميداكتا اللي هو موفرها هنا في اوكسفورد، وقال لي ان هي ما فيش مكتب، ما لقاش اونلاين على الويب سايت بتاع الشركه بتاعه في مكتب في مصر. وحاليا زمر شكلها منزله اللي هي الكاينماتيك جيجز، بس ما اظنش لسه افيلبل في حتت كتير. بس I'm sure دلوقتي كل الشركات بتحاول توفرها، فممكن يكون من الحاجات اللي تظهر قريب ان شاء الله.
هو في بجنانو موجود برضو في شغال مع حداد، مش بجنانو بيشتغل في ميو كلينيك. انا شفت في البيبر اللي انت حاططها بجنانو موجود في بجنانو في ميو كلينيك.
ده حضرتك معلش في انهم بيبر فيهم اللي هي
مع حداد؟
لا هو
حداد.
ساعات بيبقى مالتي سنتر ستاديز، بس حداد والاوفر الاولاني الاثنين في امبيريال كوليدج.
صح كده، وبجنانو من ميو كلينيك.
ممكن انا هي ما عرفتش الاسم، بس اللي متاكد منه اول واخر اسم في لندن.
ما هو يعني هو دلوقتي في ميو كلينيك بيشتغلوا شغالين ريسيرش على الكاينماتيك الاينمنت اكتر من الميكانيكال.
هي حضرتك البيبر دي كانت فانكشنال الاينمنت، ومينلي كانوا بيريفير للروبوتكس اللي بروفيسور محمد قاسم هنتكلم فيها في التوك الجايه، انها عباره عن هايبرد تكنيك يوزنج الروبوت اكتر منها كاينماتيك.
في بيبر اللي هي الكومباريتيف ستادي ما بين الكاينماتيك والميكانيكال اكسس، اللي هي بجنانو كان اخر واحد، ومعاه الراجل التاني مش عارف اللي هي بيبر كبيره،
هبص
اللي هي 10 سنين فولو اب.
اللي هي لا ال 10 سنين ال 10 years follow up، انا بحاول اجيبها بسرعه. ايه دي كانت اللي هي بتاعت ستيفن هاول في امريكا.
ايوه
دي اللي هي ستيفن هاول ايتال امبلانت سرفايفل ات 10 years، وفي ال 20 years دي من امريكا، دي كان بيتكلم على الميكانيكال الاينمنت. دي الميو كلينيك دي حضرتك البيبر دي مش كاينماتيك، دي كانت ميكانيكال الاينمنت. بس قارن بين العيانين اللي بالميكانيكال الاينمنت كان لقوا عندهم 0 بلس اور ماينس 3 ديجريز، بالعيانين اللي عندهم مال الاينمنت اكتر من 3 ديجريز. جاست التيك هوم مسج ان حتى اللي عندهم اكتر من 3 ديجريز وما كانوش محطوطين ميكانيكال الاينمنت 0 ديجريز، لسه الريزلتس بتاعتهم كانت كويسه، بس ده ما كانش، لا حضرتك ما كانوش يستخدموا كاينماتيك.
تمام. بس انت تتوقع ان الكاينماتيك ده هيبقى المستقبل يعني؟
سامعيني كده يا دكتور عادل؟
ايوه تمام يا دكتور محمد، احسن ياما.
طب الحمد لله.
حضرتك انا ممكن ما يبقاش الحقيقه، يعني لسه محتاجه لونجر تيرم ريزلتس. هو اللونجر تيرم ريزلتس حاليا اباوت 10 سنين، في اللي هو دكتور هاول في امريكا، وفي تشارلز ريفيرا، وبرده في اوكسفورد. لسه الريزلتس المبدئيه كويسه، بس طبعا التوك دي مش عشان اقول ان الكاينماتيك الاينمنت لازم تكون التكنيك اللي جاي، بس ده بس كسمري ان هي في احتمال فعلا تتيك اوفر ديبندنج على اللونجر تيرم ريزلتس بتاعتها.
تمام يا عبد الله، تمام.
الصوت كده احسن يا دكتور عادل؟
تمام، اتفضل يا دكتور محمد.
تمام.
يعني هو
دكتور محمد بعد اذنك، انا
بعد
اسف،
اذنك.
هو الصوت جميل، بس بعد اذنك حضرتك لو تعرف تعمل ميوت لللابتوب، يعني حضرتك توطي صوت اللابتوب نفسه عشان نسمع صوت حضرتك مرتين، مره عن طريق ان احنا نسمع حضرتك من السماعات ويعمل لوب مع المايك. حضرتك وطي السبيكر بتاع اللابتوب بس.
انت بتطلب مني حاجات كتير قوي.
معلش يا بيه، انا اسف. انا عارف ان الحاجات دي خلصت، معلش انا اسف.
والساعه 11:30 عندي بالليل، يعني انا اسف انام يعني.
انا اسف يا بيه والله، انا اسف انا اسف انا اسف.
انا مش لاقي السبيكر اللي انت عايزني اوطيه ده اصلا.
هو كده عموما الصوت حلو قوي.
نوطي صوت اللابتوب.
الصوت حلو قوي يعني.
خلاص خلينا بقى كده حلوين.
خليك
فهو
توقع
يعني هو عشان برضو حضرتك اللي ايه اللي الاتنتيز اللي معانا احنا بنركب التوتال ني في الفتره اللي فاتت قبل الكونسبت بتاع كاينماتيك ان ميكانيكال الاينمنت. ايه الكونسبت بتاع الميكانيكال الاينمنت؟ ان انا بعمل نيوترال الاينمنت عشان انزل اللودز ايكوال على الارتفيشال بوليسيلين انسيرت بتاعي، عشان اخلي اللودز تبقى بريتي ماتش ايكوال، وبالتالي اقلل فرصه الوير. الكاينماتيك الاينمنت اللي هي reproduction of the normal varus alignment of the tibia، مش كده؟ معايا يا دكتور عبد الله؟
تمام.
وكوينسايدنج معاها الفيمر، على اساس ان ده النورمال اللي ربنا عمله. الخوف من الكاينماتيك الاينمنت ان انا لو ابتديت ان انا افولو اب الكاينماتيك الاينمنت من غير ما اكون ريستريكتد، وعشان كده انا ميال للكونسبت اللي انت قلت عليه بتاع الريستريكتد، ان انا ابتدي احط my knee in an alignment which will induce early wear. And I have to be putting into my consideration in my mind that I am not recreating what ربنا عمله. No, I am doing something artificial. The patient has to know that this is an artificial joint. Patient has been not easy for them to appreciate and accommodate the new processes في الأول، وده اللي مخلي in favor of kinetic ان هو هيديله normal feel من الاول. انما بعد وقت الناس بتاكوموديت ان this is artificial وابتدوا يتعاملوا معاه. ف يعني I think kinematic alignment within the 3 degrees of varus والminimal deformity okay is a very good. and اصلا الستاديز كانت showed ان there is around 3 degrees of permissible mal alignment which is can go with ان احنا نقول 3 degrees دي of normal alignment before starting to having problems with wear and things like this. So يعني I think kinematic alignment is something which we should all be looking at, but at the same time putting on consideration the excessive bone wear and the excessive malalignment. If you allow me to go to my next
تمام. شير السكرين يا دكتور محمد، يلا شير السكرين.
So my next talk will be on my next talk will be on robotic assisted total knee replacement. I'm quoting طبعا late Mr. حلمي فكري. This part of the talk will be related to some of the research we've done together. الله يرحمه. So we just heard the sharing is okay. You can see and everything is okay. Fine. Carry on.
لسه بس مش ما بدأش الشيرنج عندي. بدأ
دلوقتي.
تمام.
كده وصل؟
تمام دكتور محمد اتفضل.
تمام. واضح ان في ديلي، بس هنحاول ان احنا نظبطه مع الصوت. ف as I said this talk I'm quoting دكتور حلمي فكري، طبعا كلنا عارفين الله يرحمه، with me because part of the research which I will be talking about was done with him. As we heard from Dr. Abdallah, any arthroplasty surgeon going to undergo a knee replacement with a concept whether of mechanical alignment or kinematic, mechanical alignment or kinematic alignment, should have into his mind a plan, and this plan can be preoperatively and intraoperatively executed through visual navigation, which most of the cases are done with, or through the use of a machine. And this use of machine can be either one of the 3 options here. So it can be either through a computer assisted surgery or navigation assisted, which refers to a device that has an interface that allows entry of anatomical data this entry of the anatomical data can be either pre-operative or intraoperative through registration, and then gives feedback to a surgeon regarding alignment of implants, overall alignment of the knee, but cannot be programmed to perform a task. The other second option is the robotic systems, which generally provide similar feedback to the computer-assisted surgery system, but can also be programmed to assist in the execution of certain surgical tasks, which is the robotic system. And the third one is the custom-made or patient-specific knee replacement, which can entail only a custom-made cutting jig after pre-operative planning and pre-operative input of data related to the anatomy of the knee of the patient, mostly through CT scan, with or without a custom-made prosthesis. So you can either have a cutting jig with custom-made only, and you put the prosthesis which is available in the market, or you can have also a custom-made prosthesis. When we come to robotic-assisted knee replacement, the surgeon uses the robotic device to undertake the planned femoral and tibial bone resections within the confines of the preoperative surgical plan. So there is a preoperative surgical plan. You put the plan whether you want to be heading into kinematic alignment, mechanical alignment, and then you start the execution of this plan, and the robot will help you, which can be either with fully active or semi-active, depending on the degree of control that the robotic device provides the operating surgeon. So this is an example of this bear which is controlled by the sensors to the preoperative plan, and then you start bearing the bone to the desired amount of bone resection. And this is usually color-coded on the screen like this here, until you achieve the desired bone resection, which related to the plan you have put either preoperatively through a CT scan, an MRI, or an X-ray, or intraoperatively through registration of the bony landmarks of the knee. And optical motion capture technology is used to assess the intraoperative flexion and extension gap. So you have continuous assessment while you are working of the joint stability, range of motion, limb alignment. So everything is still under assessment while you are working, which allows the surgeon to make live on-table modification to the implant position and bone resections, and permits fine-tuning of soft tissue releases to achieve the desired bone coverage, component positioning, knee kinematics, and limb alignment. So it helps you to achieve your final plan, which was decided on. There is a lot of types of robotic machines. And when we start relating them to our factors of success for any knee replacement, which includes the precise limb alignment, appropriate balance of the soft tissue envelope, rectangular and equal flexion and extension gaps, restoration of the joint line, decreased trauma to soft tissue, it's very obvious that robotic or computer navigation can help you to achieve all of these goals. So, as we heard from Dr. Abdallah also, that there is some studies which had showed that or a good number, up to 1/3 of TKA, fell outside the range of your target. And when you go outside your range of the target, you have an increased loosening rate up to 24%. So when you go with your knee in a malaligned position, which the robotic and the computer assisted surgery will help you not to happen. You fell into an increased risk of loosening because of the malalignment. And a lot of studies have shown that correct alignment can be achieved more with the computer assisted surgery rather than the manual technique. You can see here 93% compared to 75. So why visual navigation is still the standard? This is the question we should all start to think about. There is a reason why we still, or in all the world, most of the knees are done with visual navigation. I quote here this statement from the Journal of Arthroplasty that although the promise of robotics remains seductive and should be pursued, objective scientific evidence must necessarily precede its general implementation. So let's do some objective scientific evidence review. And we'll start with this. So in clinical orthopedic, which is, does robotic assisted TKA result in better outcome scores or long-term survivorship than conventional TKA? This is a randomized controlled trial, including 750 robotic versus 766 conventional knees, with a follow-up of a mean of 13 years, which has proved that there is no difference whether in the radiographic measures or survivorship or patient-reported outcome measures between both, which is a very recent study done in 2019. And even when a study shows that computer navigation for total knee replacement reduces the revision rate for patients less than 65 years of age, we find that the difference is not that significant. So it is 4.6% in navigation compared to 5.2%, which is non-significant. And this paper, no alignment data has been quoted. When we go to another study done and published in 2019 with the effectiveness of robotic hip and knee arthroplasty on patient-reported outcome, a systematic review and meta-analysis, including 14 randomized controlled trials or prospective cohort, including up to 1,342 patients. With evaluation of the risk of bias, the strength of evidence, and the follow-up, we find that all had risk of bias. The grade of quality was low to very low, with no difference in the patient-reported outcome. And when we go for another comparison of long-term outcome of computer-navigated and conventional meta-analysis of randomized controlled trials published also in 2019, including 9 randomized trials with a follow-up more than 8 years of more than 1,000 navigated and conventional, with conclusion that there is few significant differences as regards the alignment and revision, with navigation trends to be better, but no difference in the patient-reported outcome measures. And finally, also, when we go through this international orthopedic publication in 2019, assessing the manuscript conflict of interest, the funding, scientific quality, and bibliometrics between the robotic and the standard uni-compartmental, we find that there is more conflict of interest, less impact of the journal factor, and related to the robotic than the traditional, with a higher level of evidence related to the traditional. So there is arguments against navigation which make the visual navigation still the standard, including that it is expensive. And so far there is no evidence that it improves survivorship or patient-related outcome measures to the extent to be the standard, and it is time-consuming in the hospital where time matters. This will take us to the second part of this talk, which the publication I have published with Mr. Helmi Fikri in Current Orthopedic Practice, which was titled Computer Navigated Knee Replacement, How to Get It Right and at the same time Quick, which has tackled the issue of the time. And I will take you through it quickly. So this included from 2006 up to 2010, 223 navigated knees. The idea about this study was that the first 10 navigated knees were video recorded after obtaining the patient consent. Surgery time was critically analyzed, and then improvements were implemented, as we will see, and 11 operations were re-recorded at the end of this number of knee replacement, and the same data was collected and compared. We have divided the operative procedure into 6 steps, starting from the exposure, registration, soft tissue balancing and planning, femoral cuts and final preparation, implantation, and closure. And this video recording included 2 channels. So one channel was recording the screen of the navigation, and the other channel was recording the surgeon itself while operating to criticize the steps and the performance of the steps. As we said, starting with exposure up to the closure, the first step included the arthrotomy, removal of menisci and osteophytes. The second step included the registration, starting with trackers, placements, recording of the center of the hip, or registration of the center of the hip, the femoral axis, epicondyles, wide side line, condyles, anterior cortex, malleoli, tibial axis, tibial plateau, preoperative deformity, and range of motion recording, because this system doesn't have pre-operative registration. You register the anatomy of the patient intraoperative, and this is an example of registering the preoperative deformity. And the third step, which is soft tissue balancing and planning, including the tibial cut planning, tibial resection, soft tissue balancing, and femoral planning. Here, an example of tibial resection, and then planning of the gaps, and followed by the planning of the femoral component size-wise, as well as rotation, as well as how it affects the flexion gap, the rotation, everything. So you can see that there is some I don't know how can I cannot see, but on the right part of the screen, I'm trying to get the laser here on the right side of the screen. Here you can find that there is buttons you can press, and these buttons which you can press, I don't know if you see my laser pointer or not. This can help you to change, as I said, the size, the flexion extension of your femoral prosthesis, a lot of things which can help you to achieve your goal of flexion and extension gaps. So these buttons you can press, and then they can fine-tune your planning. The next step, which the femoral cuts and final preparation, including the distal femoral cut, anterior femoral cut, chamfers, finishing the tibia and preparation, finish the tibia preparation and trial reduction. Fifth step, including verifying the trials, cleaning the bony surfaces and implant components with or without cementation. And here you can see with the final trial and assessment of the final alignment with the navigation. And the last step was the closure.
And you can see here that when we assess this first series, we find that there is a big difference between the 10 cases as regard the range of time. So you can see, by example, exposure ranged from 9 minutes up to 17 minutes. Registration ranged a lot from 7 minutes up to 21 minutes. There was a big variation between cases. And this was our goal, to try to standardize into a less time as much as we can. And you can see here that the total even ranged from 65 minutes up to 113 minutes. So we have studied this first 10 cases, and we came to that the main factors affecting the surgery time was non-standardized techniques, experience of the surgeon or the learning curve of the support staff, and the frequent bony cuts to achieve the plan. And this was the 4 main factors which we worked on. So for this non-standardized technique, as an example, the exposure used for the first 10 cases was variable. 5 medial parapatellar, 3 mid-vastus, 2 sub-vastus. So a decision was taken that the exposure to be standardized for the other remaining cases to mid-vastus for all cases. As regards the learning curve of the surgeon, we applied the 4 steps of learning, or the conscious competence matrix, which start by being unconscious that you are incompetent, and then you are conscious that you are incompetent, then you are conscious that you are competent, and then you are unconscious that you are competent. Through realizing that there is a problem and studying the problem, and then implementing the changes, and lastly, practice. And the good thing which has helped a lot in this is that Mr. Helmi Fikri has taken a decision to do all the knee replacement through navigation, not only the cases with severe deformity, but all, and he has encouraged us as his fellows to do the same. So we used to do as much as we can of our knee replacement through the navigation, which can help to get more practice and less time consumed. As regards the learning curve of support staff, he has invented this very nice photo, which I recommend for anyone, for any sophisticated surgery to do, that he can apply it. So what he has done is, this photo was hanged in the preparation room in the theater, and you can see that he has put here the instruments, and in the order we use them in the surgery. So any theater staff, scrub nurse, which was there, whether the one which is used or unused, she sees the photo and just start preparing the table with the same order, which make it very easy for her to start handling and giving the instrument to the surgeon in the same order which he used them, which lessens the time in looking for them, and have made a very big difference in the learning curve of support staff. And you can apply this for any surgery you do, which entails a lot of instruments, really. For the assessment of the bony cuts, we have assessed the tibial resection, the distal cut, the anterior cut, and they were assessed as regards the deviation from the plan. So there is a plan by the computer navigation, and then we do the cut, and then we verify the cut. And we assess the amount of angle which was deviated from the plan after the first cut in degrees, as well as the number of cuts we have done to achieve the planned angle of cut by the navigation. As you can see, that we found that some of the cuts, like the tibial cut, we had up to 4.5 degree of deviation, and up to 3.5 number of repetition of the cuts to achieve the planned cut, which was very time consuming to do the cut 3 or up to 4 times to achieve the target. So started working on this to improve it, implementing some changes. So for the tibial cut, for example, which more repetition, we started to leave the cutting, the guide, the extramedullary guide, we don't remove, which was helped in stability. We started putting up to 3 pins to hold the cutting guide so it helps not to move. We started to use and make sure that we use the power tool instead of the air saw, which is lighter and you can control better. And we started to use the prismatic saw blades, which is prevent the coagulation of the bone on top of the blade and help not to change, to transform the blade from a saw into an osteotome, and will make it sharp all through the cut and precise. So this is the 3 things, and this has significantly helped to improve the number of the repetition, as you can see here, from 3.5 up to 1.4 for the tibial for a cut, for example, with significant improvement. And as you can see here, this has helped also in significant improvement of and decrease of the surgical time in most or all of the surgical step, especially the ones which related to the computer navigation. It was expected that the implantation one will not differ much because it not entails any new skills. And you can see that we achieved around 36% of improvement in the time of the whole surgery. And looking at the curve with the green one representing the navigated knees, we achieved the surgical time to be even less than the red one, which represents the non-navigated knees at the end. And we assess the clinical function of the patients also, comparing the 2 groups to make sure that the reduction in time did not affect the function of the patient or the results, and there was no significant difference between the post-operative oxygen knee score of group A compared to group B. To conclude, critically analyzing and improving the technique can reduce surgical time, and I just recommend this for anyone, not necessarily for the knee replacement or the computer navigation. You can use this in any of your surgery which you think that you need to improve your surgical time. It is possible to use computer-assisted surgery in performing TKR in less time than the standard technique. Visual navigation remains the standard practice up till now. Thank you very much for attention. and يعني الله يرحم دكتور حلمي، يعني طبعا هو he has been helpful for a lot of our colleagues in the department. يعني.
الله يرحمه دكتور محمد، الله يرحمه. شكرا جزيلا دكتور محمد for a very nice talk. But I have a question. What do you mean visual navigation is still the standard?
Visual navigation is what we all use. The visual navigation means you use your eyes. Visual navigation is eyeballing. You eyeball your jig, you eyeball your resection. You may use the extramedullary guide, but at the end, it's your eyes, the visual navigation, not the computer navigation.
Okay, thank you very much. So the next talk is Dr. Abdallah again. Dr. Abdallah with us.
موجود اهو. شير سكرين. تمام.
اتفضل يا دكتور.
شكرا. تمام. Next presentation I'll be talking about an update on partial knee replacement. الصوت كده تمام؟
تمام حضرتك.
تمام. برضو no disclosure relevant to this topic. Partial knee replacement, I'll be discussing medial uni-compartment knee replacement, lateral unis, patellofemoral joint replacement, and bicompartmental knee replacements. With regards to uni knee replacement, I'll start by an introduction. I'll talk about the prerequisites to do a uni, contraindications, indications, and extended indications. preoperative radiological assessment, which I feel is quite important, complications and modes of failure, and then some tips and tricks. With regards to the introduction, so unis, we know that uni knee replacement is a worldwide recognized procedure for the treatment of uni-compartmental knee osteoarthritis. Several reports have recently demonstrated excellent survival rates, more than 90% at 20 years, including work at Oxford. However, despite this, knee replacement registers still show a relatively high revision rate and failure rate of unis, especially when compared to total knee replacements. The high incidence of failure has been associated with incorrect indications and with surgical technical errors when performing uni knee replacements, therefore leading to early revisions. Recently, a lot of talks about UKR caseload, which is the uni caseload, the number of unis each surgeon does a year, and also the UKR usage, which is the percentage of unis you do in relation to the whole arthroplasty work. An interesting paper published by Tom Hamilton here in Oxford, and they concluded that surgeons who do more than 20% and ideally more than 30% of their knee arthroplasty unis will have excellent long-term results. So traditionally, these are the indications and traditional ones for uni knee replacements, and these are available on websites like OrthoBullets, for example, and still there, including age, more than 60, weight less than 82 kilograms, no significant patellofemoral OA, and low demand patients. However, there are more indications. I mean, why should we extend the indications? Or in other words, what are the advantages of unis versus total knee replacements? And these are all published in a lot of studies, including shorter hospital stay, fewer medical risks as MI, VTE, and stroke, lower mortality, less blood loss, lower deep infection, less readmission and reoperation, preservation of knee kinematics, again, an excellent functional outcome. And another reason to extend the indications is having a better UKR usage and then having better outcome. So the prerequisites to do a uni, or in other words, again, the anteromedial OA diagnostic criteria include medial bone-on-bone arthritis as in the X-ray, a functional normal ACL, a functional normal MCL, and intact full thickness lateral cartilage. And a debatable one is the PFJ. We want to make sure that there are no lateral grooving and bone loss. And in this picture, it actually shows the classic anteromedial OA, where medially after doing a cut for a uni knee, you find wear anterior with preserved cartilage posteriorly. So are these considered the contraindication? Age, weight, high activity, anterior knee pain, PFJ arthritis, and chondrocalcinosis in the lateral compartment, and lateral osteophytes. Actually, these are all shouldn't be considered, contraindications. And this is an interesting paper by Pandit et al. From the Nuffield Orthopedic Center discussing these early historic indications that actually were published in 1989 by Kassem and Scott. And they divided their patients, they had 1,000 unis, divided them into two cohorts, one with one of these contraindications and one with no contraindications. And they concluded that at 10 years, those with contraindications has as excellent results as those without contraindications. And they actually concluded that these are all unnecessary contraindications. And again, lateral osteophytes. If an X-ray shows lateral osteophytes in a medial compartment OA, it's still not a contraindication, as reported by, again, Tom Hamilton here in this paper. And he found that lateral osteophytes doesn't indicate that this patient has full thickness cartilage loss in the lateral compartment, and that this patient can still be offered a uni with excellent result at 15-year follow-up. So contraindications, I think ACL insufficiency is a known contraindication, lateral compartment osteoarthritis, patellofemoral joint lateral facet severe OA with bone loss and grooving, and lastly, MCL insufficiency. The ones at the bottom of the slide are actually relative contraindications, inflammatory arthritis, but now with new biological treatment with rheumatoid arthritis and all the inflammatory arthritis, some patients may be cured and controlled with regards to the inflammatory arthritis and end up with normal osteoarthritis. And that's why it's a relative contraindication, but still a contraindication to be considered. Fixed flexion deformity of more than 15 degrees. Actually, you can still consider uni if it's more than 15 degrees, but the worry is about the ACL integrity, because you will have a big anvil osteophyte at the front that can strain your ACL and cause some secondary ACL insufficiency. And lastly, the degree of frontal plane deformity. I know that traditionally it was meant to be 5 degrees valgus, 10 degrees varus, but actually it's more about the correctability of the deformity and integrity of the MCL. ACL integrity, so definitely this is an absolute contraindication for mobile bearing unis and lateral unis, and controversial for medial fixed bearing unis. However, we need to differentiate between primary traumatic versus secondary degenerate ACL insufficiency. So can patients with primary anteromedial OA and secondary ACL deficiency be accepted as candidates for unis, as compensatory mechanisms of knee prevent instability, or they don't have functional instability? Well, recent papers have begun to confirm that they have good short to mid-term outcome with patients who have deficient ACL, but with no functional stability. So from my point of view, I think it's still a contraindication, but if a patient is 80 years old with no functional instability, a negative anterior drawer enlargement test, with all the advantages of offering uni in an 80 years old, I think it could be a good option to be considered if he only has some degenerate change but no functional instability. Another interesting paper here. So if patient is young and has medial compartment OA, but with rotatory ACL instability, this paper was also published confirming that these patients having combined unis and ACL reconstruction can still do very well and have excellent results. This was a 52 patient study, 33 of which had simultaneous ACL reconstruction and medial uni in the same setting, with excellent functional outcome and survival rate. PFJ-OA, well, we know that lateral facet severe OA is considered the contraindication, especially if you have lateral bone loss or grooving, but severe medial OA is not an absolute contraindication. And then another paper here about the anterior knee pain and patellofemoral OA, and actually the conclusion from it is that actually these are not considered a contraindication, and patients with anterior knee pain and osteoarthritis of a patellofemoral joint did very well at 15 years follow-up. However, we need to have it is a shared decision with the patient. We need to discuss the pros and cons of having a uni, and at 15-year follow-up they had very good outcome. But we need to know that patients with PFJ-OA may have problems descending stairs with PFJ-OA. And obesity, well, high BMI is definitely known to be a higher risk with total knee arthroplasty and unis with regards to DVT risk, wound healing problems, infection. But this interesting paper again confirmed that patients who had a high BMI did not have poor outcome with unis and had good functional survival. And they divided the cohort of the patients to depending on the BMI and compared them together, and they both had excellent survival. With preoperative radiological assessment, which is quite important to identify the patients suitable to have a uni, includes a routine AP weight bearing, lateral and skyline view, and a Rosenberg view, which I think is quite important to assess the thickness of the cartilage loss, and then stress views, which are still can be done and good when someone is starting to do unis to assess the other compartments, and lastly, MRI. So with preoperative radiological assessment, for example, this patient have medial compartment OA, lateral osteophyte, and we just mentioned it's not a contraindication, but when you have a lateral view, it's important to check on the PFJ and more importantly, reveal posteromedial wear, as in this X-ray, where the patient has actually posteromedial wear, which indicates that the ACL is dysfunctional, and this patient is not a suitable candidate to have a uni knee replacement. With regards to Rosenberg view, and the figure on the right explains the difference between an AP view and a Rosenberg view. The AP will be in a straight leg, 10 degrees inclination, but the Rosenberg view will be in a 45 degrees flexed knee and a postero-anterior view, and it actually was found to be more accurate in determining the thickness of the cartilage loss. So you can assess the medial compartment and also check if the lateral compartment has no arthritis. As seen in this X-ray, this is one of the patients who had a weight-bearing X-ray showed medial OA, but the Rosenberg was more accurate in determining the narrowing of the joint space medially. With regards to the varus and valgus stress views, it's quite important, especially if someone is starting to do unis, as they can actually show the actual state of the lateral and medial compartment. This is a patient who had likely tricompartmental osteoarthritis and then had a valgus stress view, which confirmed the presence of almost full thickness lateral compartment loss. And this patient ended up with a total knee and not a uni. Another patient who had a medial compartment OA, and on a valgus stress test, it shows, first of all, the lateral compartment is still intact, and the MCL is intact, and the deformity is correctable. This patient is a suitable candidate to have a uni knee replacement. And these stress views are actually cheaper and easier to have than an MRI scan. With regards to surgical technique and tips, so it's a soft tissue referencing, it's a true kinematic alignment, and that correlates with the previous talk about kinematic alignment in knee replacements. It's a minimally invasive approach, but you need to have adequate exposure to be able to see what you're doing. Link tibial and femoral cuts. Conservative cut is very important. The sagittal cut is quite critical. We need to avoid damage to the posterior cortex, avoid lifting our hands when doing the vertical cut, avoid over resection when doing the vertical cut to avoid damaging posterior cortex, and that's why now I'm moving to doing the horizontal cut first. 90 degrees angle is quite important when you're doing the vertical cut or keel prep. Adequate sizing of the tibial component, because undersizing it risks fractures. Adequate keel prep to make sure when impacting it you don't cause any problems or fractures, and careful implantation of light hammer. So we know that unis in the registries do have a higher rate of failure. This was a good review article paper that concluded that aseptic loosening and osteoarthritis progression are the most common causes of failure in medial uni. Aseptic loosening is the most common in early failures and mobile bearing unis, whereas AO progression is the most common in late failures and fixed bearing unis. So the higher incidence of failure and revision could be attributed to incorrect clinical and radiological indications, and that's why I summarized these in the previous slides, and also some surgical errors. We discussed the UKR usage and common modes of failure: aseptic loosening, progression of arthritis, so avoid overcorrection, bearing dislocation, and makes sense it's more with mobile bearing unis. Tibial fracture is a risk, and NGR data shows that with cementless, and we're now moving to doing cementless unis, the risk is 3 times higher, and careful tibial preparation and preoperative planning is very important. So risk factors for tibial fracture is when the sagittal cut is too medial, and it needs to be just medial to the tibial spine while protecting the ACL. Another thing is a deep resection, because this risks injuring to the MCL and going more distally, may risk having a tibial fracture. Keel slot for posterior cortex, we need to make sure we don't go very posterior here to avoid damaging posterior cortex and risking a periprosthetic fracture. And keel prep is important to avoid increased strain and fractures, and adequate sizing. Having a small size tibia will risk subsidence and fracturing. So tips to reduce this, again, is a conservative tibial cut, horizontal cut first. So we cut the horizontal first, and then use one of these instruments. It's called a boomerang, which can be put where the horizontal cut is before you do the vertical cut, to avoid over resecting and going more into the posterior cortex and damaging it. Light hammers, again, I just mentioned, so use a small hammer and lightly hammer, not like with a total knee replacement, to avoid any fractures. In this X-ray, there are a couple of things that could have been improved, including the vertical cut. So if that's the tibial spine, the vertical cut needed to go more lateral. The keel is actually quite medial in relation to the tibial cortex, so that's another mistake here. The surgeon was misled by the big osteophyte medially. And lastly, in the lateral view, the keel prep is quite posterior, which risks having a tibial fracture. Then next slide is patellofemoral joint replacement, which I'll be quite brief because of time. So patellofemoral OA can be associated with anterior knee pain, stiffness, and functional impairment. It preserves physiological tibiofemoral joint, rapid recovery, good satisfaction, but careful patient selection is quite important. Ideal candidate is a middle-aged female, example in the 40s, with severe patellofemoral OA, failure of conservative measures, but without significant malalignment or tibiofemoral osteoarthritis. Those secondary to trochlear dysplasia always usually do well with patellofemoral joint replacement. Elderly patient more than 80 with isolated patellofemoral osteoarthritis can actually do well, especially that the advantages of the partial knee replacement for these patients are usually quite advantageous. With regards to proper patient selection, we mentioned this, and the new implants, the outcomes are getting even better. So with the indications, we know it's severe primary isolated patellofemoral osteoarthritis that affects the daily activities without relief from the conservative treatment. With regards to contraindications, the presence of tibiofemoral osteoarthritis is the most common contraindication and actually most common mode of failure. Others include fixed flexion deformity, varus valgus malalignment, and systematic inflammatory arthropathy, chronic pain, regional syndrome, and infection. Quickly through the implant designs, in 1950, McKeever reported the first study with 40 patients using this implant on the right, top right, and these all had complications. It addressed only the patellar side with no trochlear replacement. Then in 1970, the first generation was introduced. These include the Richard II and the Luminous. The problem that these had a lot of complications because they were dependent on the anatomy of the native trochlea. And again, the second generation was then introduced, which includes the onlay, had a broader trochlear surface, improved geometry and valgus tracking angle, which improved the functional outcomes. An example of these is the Avon and Gender solutions, and recently the custom-made patellofemoral joint replacements. With radiological assessment, again, the AP, the lateral, the skyline are the basic ones, and including Rosenberg views, which I discussed before to check on tibiofemoral OA. Skyline view is quite important. Long alignment views if we're worried about obvious malalignment, and MRI, which can assess the patella alta, TTTG, intra-articular pathology in the tibiofemoral joint. And this is an X-ray of a patient who needed to have both an osteotomy and PFJ replacement. So comparing it to total knee, it has fewer complications, less blood loss, and better post-operative flexion. However, the numbers of patients who are offered or have PFJ are quite small compared to total knee. In the NGR in between 2003 to 2014, it was only 1.3%. Several studies confirmed that PFA could be potentially delayed total knee by about 10 to 15 years. It still remains controversial due to the high revision rate in a lot of the registries, including the 12 annual report, 19 versus 3% when compared to total knee. So this paper compared the complications of PFJ versus total. They reported higher complications with PFJ replacements, but when they analyzed this further into only the second generation PFJ replacement to total knee replacement, they found that they had better outcome and less complications. A very interesting paper about patellofemoral by Dr. Ogaard et al. In Denmark, and actually he had 2 years follow-up in a randomized study, and he found that these patients had a higher knee-related quality of life and range of motion, but still long-term follow-up is needed to check on long-term survivorship. With regards to bicompartmental knee replacement, which is the last part of the talk, 66 years old female, BMI 39, had a medial uni in 2012. Very satisfied with it. Then 8 years later, came with this progression of arthritis in the lateral compartment. So the most common way of treating this will be converting this to a total knee replacement. But this patient had a bicompartmental knee replacement by adding a lateral uni to the lateral compartment. This patient is quite satisfied with the results and actually came for the other side, asking to have the same. So for bicompartmental knee replacement, it could be a medial uni with a patellofemoral joint replacement or a medial uni and a lateral uni. It has the advantages of preserving the bone stock and sparing the ligaments. It's technically demanding. It could be done as a primary where you simultaneously do both, or as a revision as the one I just presented. And there are new custom-made implants. This is a systematic review of bicompartmental knee replacement showing excellent short-term to mid-term results, and these patients had better range of motion and the knee felt more normal to them with less intraoperative blood loss, but still they have poorer long-term survivorship, and definitely we need to wait for longer-term results. So further long-term studies comparing both have to be performed before definitive treatment recommendation can be done. So conclusion-wise, we discussed the unis, extended indications and unnecessary contraindications. We discussed the usage, importance of radiological assessment, including the stress views and Rosenberg views. And we mentioned the PFJ replacement and compared it to total knee. And finally, the bicompartmental knee replacement. Thank you.
Thank you very Abdallah
Thank
for
you.
very yes.
Thank you.
تفضل تفضل.
تفضل بيه اتفضل محمد اتفضل.
Thank you very much, Dr. Abdallah, for this very nice talk here.
Thank you. Thank you.
Any questions?
So I want to ask Abdallah about he didn't mention the upper tibial osteotomy, which was the talk of Dr. Ahmed Wali, but unfortunately he's sick.
لا هو طبعا دكتور عبد الله لازم يكلمنا على دي، بس هو برضه putting into consideration in the British school was more towards the replacement side rather than the osteotomy side، صح؟ بس now عندكم البازنجتون team وعندكم كذا تيم دلوقتي started to be with osteotomy، ولا ايه رأيك؟
تمام حضرتك. طبعا في اوكسفورد الميديال يونيز ار مور بوبولار، بس في اوفرلاب صغير في الانديكيشنز. بيزنج طبعا بيعملوا اوستيوتوميز اكتر. For someone who will be around late 50s to 60s, unis is usually a better option, but still debatable. و I think الاوفرلاب بسيط، يعني لو someone في الاربعينات ولسه not full thickness bone and bone osteoarthritis with an obvious varus deformity, then definitely a high tibial osteotomy could be a better option, especially if he's young with still no full thickness cartilage loss on both sides.
تمام. هو طبعا لو انت سمعت بتوع البازنجتون سكول او تيم بيتكلموا ممكن يقولوا they are over indicating their patients selection.
تمام صح.
وده expected for both schools. يعني زي برضو ما now انت اتكلمت على over indication للreplacement, which I think should be something to be very careful with. There is as you said, the choice and selection of patient is very important, and the technique is very important. When we come to more indication, age-wise, weight-wise, or patellofemoral arthritis-wise, we have to be very careful, especially in our starting learning curve, to avoid frustration from the result of the patient and the failure. But at the end, both schools now are indicating more indication, increasing their indication. Yeah. When I remember very well in my first uni-compartmental I helped with was an around 70 years old patient in France, Professor Chiron, one of the very good surgeons in Toulouse. And I asked him, this is very old. And this was in 2007. And he had this concept, which now we are talking about 13 years later. I'm correcting the alignment. I'm replacing the damaged compartment. The patient do very well. And the first French surgeons, usually they are very, very courageous to do things more and less conservative than the British ones. And he has a very good experience with this, yeah. I agree with you. This is a very good option, less bone damaging or bone preserving, yani. But the choice of patient and the technique has to be considered very, very well. And we move to the last talk, inshallah, Dr. Abdallah. I'm seeing if there's any question. So
share screen.
I think there is one question. So it's not the degree of varus or flexion deformity, but about correctability.
تمام. هو traditionally كان دايما بيتقال ان 5 degrees valgus للlateral unis و 10 degrees for varus، بس it's more important الانتجريتي بتاعت الام سي ال. والاي سي ال والكوركتابيلتي بتاعت الديفورمتي، لان لو هي مش اللي احنا المفروض ما بنعملش سوفت تيشو ريليز مع اليونيز زي كاينيماتيك الاينمنت، فلو هي مش كوركتبل معناها ان الام سي ال سكارد ومش هيبقى كوركتبل جاست وفي يوني، وهيبقى في مشاكل ساعتها.
تمام. ده برضه اهميه البري اوبراتيف اسسمنت، مش
تمام.
كده؟ اللي هو تشويس سelection of patient، وزي ما انت قلت يعني there is a lot of tools to be done. يعني if you want to do stress views, do if you're not convinced do MRI. Some of the cases may end up doing even arthroscopy
تمام صح.
to make sure that you are heading into the right diagnosis يعني.
تمام. وبالنسبه حضرتك للفيكس فلكشن 15 ديجريز تراديشنالي، هي ده الكلام ده اكيد بيطلع مظبوط للاخر، لان لو اكتر من كده الاي سي ال ساعات بيبقى خلاص insufficient، وفي نفس الكلام فارس مور ذان 10 to 15 ديجريز عاده الام سي ال بيبقى سكارد، بس الاهم فعلا من الفيجرز نفسها الكوركتابيلتي بتاعت الديفورميتي.
ممتاز ممتاز. Thank you very much Dr. Abdallah. May I ask you يعني to proceed with your last talk?
تمام. Just share screen. So last talk about evaluation of use of metaphyseal augments in revision total knee arthroplasty, which actually I'm happy I had an opportunity to share this, which was the thesis, PhD thesis work with Professor Hani Morsi and Professor Dr. Tariq Al-Khadrawi and Mr. Helmi Fikri, Allah yarhamu. So first of all, with the introduction, as the incidence of primary total knee arthroplasty continues to grow, the number of revision procedures is also expected to rise. It's a complex procedure, requires detailed planning, meticulous technique, and skill. Focus has been placed recently on efforts to improve implant stability to ensure long-term stable fixation and to manage bone loss in revision total knee arthroplasty. We have a lot of goals we would like to achieve in revision knee arthroplasty, but more importantly, also with regards to the talk of today, is the restoration of joint line, solid fixation of the implant, and management of bone defects and reconstruction of bone deficiencies. So we have a lot of challenges in revision. The most important with regards to today's topic is bone loss. Bone loss and implant fixation. So the management of bone loss is challenging in revision total knee arthroplasty, despite of the presence of variety of options to the surgeon. We are often faced with bone loss that may compromise the fixation of the new component. Bone loss may occur as a result of the original disease, the design of the prosthesis, the mechanism of failure, whether infection, osteolysis, or mechanical damage, and lastly, technical error at the initial surgery. So the management of bone loss is dependent upon the site and size of bone defect. Bone loss can vary from minor contained defects to severe large uncontained defects. An accurate determination of the site and amount is critical in determining the appropriate reconstruction method in revision total knee arthroplasty. So small bone defects have been traditionally treated with morcellized cancellous bone graft, cement plus or minus augmentation of screws, but actually is not done anymore, but was traditionally done, and the use of modular augments, which actually is the most common method of reconstructing small bone defects, as seen in this picture with distal and posterior augments. While with larger massive bone defects, impaction bone grafting, structural allografts, custom prosthesis, or specialized knee systems as distal femoral replacement option, allograft prosthetic composites, and recently sleeves and cones. Two papers here, the first discussing the results of structural allografts, which is now falling out of favor because of the complications, the risk of reoperation, infection, non-union, graft failure, and resorption. And next about the tumor type and hinged implants. From my point of view, I think it should be the last resort and not to directly jump to a distal femur replacement to tackle bone loss in the metaphysis, but to consider metaphyseal augments first. The use of metaphyseal porous metal devices in whether cones or sleeves has gained recent popularity in the last years with promising short and mid-term results. The body of the literature and interest surrounding metaphyseal porous devices increased dramatically in recent years. So sites of bone defects and zones of fixation. So it's recently described now, the zone of fixation is quite important in preoperatively planning the method of reconstruction. So traditionally, we've used zone 1 and zone 3 for fixation, which is the revision knee implant, mostly with a stem and a revision implant. But zone 2 metaphysis was not actually used at that time. And very recently, there's been an interest in targeting this area for construct stability during revision knee. Sleeves or cones are available, both giving additional options for fixation in zone 2. So what are the advantages of zone 2 fixation? Zone 2 is usually well preserved, vascularized, undamaged, with better bone quality when compared to the zone 1 that is deficient and unsupportive in a revision knee replacement. And secondly, is loading this metaphyseal area can reduce the stress shielding and provide greater torsion and rotational stability. And also fixation closer to the articulation can facilitate restoration of a joint line and also, again, rotational alignment control. The disadvantage of zone 3 only fixation is that you can do stress shielding with bone loss, and secondly, and more importantly, stem tip pain. And when you depend on a big stem to fix your revision implant, the patient can end up with a stress concentration at the tip and some pain. So example of metaphyseal fixation implants include sleeves by Dupuy, titanium cones by Stryker, and the tantalum poplar cones from Zimmer, and now more companies are introducing their own metaphyseal augments. The similarities between these two is both are zone 2 fixation, high coefficient of friction to guarantee primary stability, high degree of porosity to ensure bone growth and long-term stability. But the difference is that the sleeves have a more taper and they have a stepped geometry, while the cones can be implanted independently of the stem and require a stem interface between the implant and the cone, but make sure that the outer border with the bone will not have cement in it to allow integration of the bone. Both have different field of application, but from my point of view, they're both functioning in with the same principle. So fixation and augmentation with sleeve and augmentation with cones. Currently no randomized trial comparing both. Our main question was, is metaphyseal fixation a reliable tool to construct stability and managing severe defects, type 2 and 3 Anderson classification? And does the use of these sleeves present a good option for management of bone defects? The aim of the study was to evaluate the clinical and radiographic outcome of the sleeve in managing bone defects and revision knee replacement. We included all patients between 2008 January and August 2016, all patients who had sleeves used in the femur, tibia, or both, with a minimum follow-up of 2 years. We had 57 patients who had metaphyseal sleeve, 55 met the inclusion criteria. These were the demographics, so 55 patients, 29 male, 26 female, average mean age of 75, follow-up of 58.7, with mostly ASA 2 and 3. And we used the Anderson Orthopedic Research Institute classification for classifying the bone loss. Indication for revision was mainly aseptic loosening, 33 patients, and infection, 12 patients. With the surgical technique, we used the medial parapatellar in all patients. One had a quadriceps snip. No patients needed a tibial tubercle or a quadriceps turn down. All were done, all revisions for infections were done in 2 spacers. First stage with a dynamic spacer K, followed by a second stage. Started with removal of components, making sure we don't lose more bone, and then preparation of the tibia by reaming the tibial canal, then broaching with the metaphyseal broaches here, and sequentially increase the size till we achieve good rotational stability and fill the metaphyseal defect. The proximal tibia is then cut over the sleeve to refresh the tibial cut, and then we could not use augments distally around the tibia with the sleeves. Preparation of the femur went into the same steps, so start with the reaming the femoral canal, then broaching the metaphyseal area with the broaches till we achieve good stability. The broach is then left inside and attached to a threaded shaft, which is attached to the distal cutting jig, and we can then cut the distal femur, cut the chamfers and AP cuts, and then box prep. And this helped us with restoration of a joint line, because the correct size sleeve should fill the metaphyseal bone defect and achieve stable contact with cancellous bone. Using a bigger sleeve will facilitate more proximal positioning of the tibial tray, more distal placement of the femoral component, thus restoration of a joint line. Then trial the components and checking the gaps, any soft tissue release if needed. then assembling the implant while trying to match the same rotation of the sleeve on the trial while implant assembly, and then implanting our implant. So only 2 patients needed bone allograft, and these were earlier in the cohort when this was a popular method of reconstruction. And the last X-ray shows that actually the graft mostly resorbed, but the sleeves were still well integrated and had no loosening. So implants used, 39 were TC3, which is a semi-constrained Dupuy implant. 15 patients were hinged Noyles knee replacement, and 1 was a PS. And we had 93 sleeves used. The results actually, we checked on the radiological outcome, the clinical outcome, survival analysis, and complications. With regards to the radiological outcome, all sleeves, 92 sleeves had well integration with no problems, no loosening. Only 1 patient with 1 sleeve had loosening and needed a revision. So the knee score was used to check on the functional outcome. The mean Oxford score improved by 16.4 post-operatively. So I'll just present some of the patients what we had. The first is a 62 years old who presented with a septic loosening of his total knee replacement and a pre-operative Oxford score of 17. He had a single stage revision with sleeves on both the tibia and the femur and a TC3 semi-constrained implant, and final results at 7 years post-op of good integration. Another 82 years old who had obvious aseptic loosening, infection was excluded, had a TC3 with sleeves in the femur and the tibia, and he had an allograft here with sleeves to reconstruct the metaphysis. Final X-rays at 6 years shows well integration of the sleeves with no loosening, with some resorption of the allograft. Third patient is a patient in the 60s with again aseptic loosening, had again revision of TC3 sleeves in both the femur and the tibia with excellent outcome at 8 years. A fourth patient had obvious malalignment with MCL insufficiency and needed a revision in a single stage using a rotating hinge, Noyles with sleeves in the femur and the tibia. 7 years results of excellent outcome and no loosening. The fifth patient was a patient who had infection, post-knee replacement, needed a 2-stage, first stage with a dynamic spacer, second stage with a TC3 with sleeves only on the tibia. The femoral bone loss was found to be all right with no sleeves needed. And these are the final X-rays. So complications, we had fractures in 2 patients in around the tibia, detachment of the patellar tendon, partial detachment in 1 patient, stiffness in 1, patellar clunk syndrome in 1, and recurrence of infection in 2. Intraoperative fractures, these were 2. 1 actually was quite peripheral and didn't affect the stability of the implant, and we just protected the weight bearing for 6 weeks. The second needed a screw with protection of weight bearing, neither of which needed a revision later on. Patellar tendon detachment partially in 1 patient, and with regards to the survivorship, 98.2% survival rate for aseptic loosening and 96.4% for overall loosening, with 1 for aseptic loosening and 1 for infection. So this is one of the revision for infection. He had sleeves on both sides, but the infection recurred and he started having bone loss here just behind the femoral component. And he had a 2-stage revision, and to actually reconstruct his distal femur bone loss, he needed a distal femoral replacement. So to conclude, direct cementless fixation by sleeves is a promising option for implant fixation, both on the tibial and femoral sides. Sleeves provide stable fixation structure support in patients with significant metaphyseal bone loss. Sleeves are versatile in their ability to fill the bone defects of variable sizes and can help in restoring the joint line. And lastly, further follow-up will be required to evaluate long-term results. However, recently there has been some publications with longer-term results in a multi-center study showing again excellent outcome. Thank you.
Thank you very much, Dr. Abdallah, for this nice very talk.
So, can I ask him a question, Mohamed?
اتفضل يا باشا.
So what do you have another options, Abdallah, to use for revision other than cones and sleeves?
حضرتك بالنسبه لو بون ديفكت 2 او 3 mainly السليفز والكونز، بس لو البون لوس اكتر و cannot be reconstructed by sleeves وكونز بنروح للديستال فيمر ريبليسمنت وتيومر بروسفيسز. بس not aware of حاجة تانية حاليا.
يعني if I can comment on this question, Dr. Adil, before having the cones and sleeves available, يعني I went through some of cases with طبعا Mr. ماهر حلاوة ومستر حلمي فكري. The patient personality was very important. So I've seen Mr. Halawa filling defects with cement for patient low demand, very activity is very limited, and I've seen him doing impaction grafting for patient young. He wanted to restore the bone. So the patient personality is important. I know that this question is related to money, because in Egypt, definitely sleeves and cones will raise the price of the prosthesis very much. So there was, and there might be still some options, less expensive, but definitely now sleeves and cones are getting more and more popular here. What do you think, Dr. Abdallah?
حضرتك طبعا I agree مع حضرتك في الموضوع اللي هم gaining more popularity، والresults اللي published في الكام سنة اللي فاتت بتبين the importance of having it as an option to reconstruct the bone loss and the metaphysis of revision knee replacement.
برضو اللي very confusing دايما دكتور عبد الله for some people اللي هو ال difference between sleeves and cones. And يعني you were lucky and I was lucky to work with Mr. Helmi Fikri, and we have يعني to mention Mr. Helmi. He was one of the pioneers in computer navigation, was of the references, and also he was one of the يعني few surgeons to start working with sleeves. And if you agree with me that there is a difference between sleeves and cones, sleeves fill defects and stability and achieve stability, while cones mainly is a filling of defects.
تمام. هو
اتفضل.
السليف طبعا بيبقى already attached للإمبلانت بمور ستيبر، وبيبقى already فبيساعد على الفيكسيشن واوجمنت الميتافيزيال بون لوس. الكونز بيبقى implanted separately فمينلي اوجمنتيشن، بس طبعا الاثنين برنسبلز مختلفين وبيأند في الاخر بريكونستراكتنج الميتافيزيال بون لوس. الكون هيبقى بيتحط اندبندنت للامبلانت بتاعي، فلازم بستخدم سيمنت عشان ابوندت مع الامبلانت بتاعي واتاكد ان مفيش سيمنت على البريفري. السليفز مينلي كلها انسيمنتد وما بحتاجش استخدم معاها سيمنت لانها اوريدي اتاتش للامبلانت بمور ستيبر. وطبعا الماتيريال مختلف بين الاثنين، فالكونز اللي زي بتاعت زيمر تانتلم كونز، وايل الامبلانت بتاع ديبوي ده ترايتانيوم، ونفس الكلام في سترايكر اوجمنتس دول ترايتانيوم.
هو السبب ان انا بقول الكومنت ده ان برضو مستر حلمي was one of the first surgeons to be courageous enough to use metaphyseal sleeves without stems.
تمام.
And يعني he used it. I don't remember if it was already indicated or not. And he achieved stability with metaphyseal sleeve to the extent that one of the surgeries I was with helping him, I said, I will not use the stem. And after this became a practice for some of the surgeons. So you can use a sleeve without a stem, but you cannot use a cone without a stem because you cannot achieve stability with the cone. This is my concept. You agree with me in this can be achieved with sleeves rather than cone stability.
تمام حضرتك. بالنسبه للسليفز في فعلا كذا publication about using the sleeves حتى من غير ستام خالص، لانها بتدي fixation and augmentation ووجود results حتى الان. وبتبقى الميزه بالذات في الريفيجنز اللي انا استخدم سليف without any stem. لو البيشنت عنده extra articular deformity مش هقدر احط ستام طويل لان ممكن يحصل periprosthetic fracture، فبرضه السليفز لوحدها can sometimes be an option.
Thank you very much, Mohamed and Abdallah, for very high quality presentations. Thank you very much.
الله يخليك. وانا بشكر حضرتك
جدا يعني
بجد استمتعنا.
بالفكره، وسعدت ان انا كنت مع حضرتك ومع دكتور عبد الله ما شاء الله يعني اهو يعني ان شاء الله ربنا
الله
يكرمك.
يخلي حضرتك يا
سهرتوني وفضلت فايق لغايه الساعه 1 اهو.
شكرا جزيلا يا محمد، والله
شكرا
تعبناك.
جدا دكتور عادل.
ميرسي
شكرا
جدا
يا عبد
الله
الله.
خير دايما
دكتور
كده.
عادل.
اهلا وسهلا.
شكرا للجميع يا جماعة، شكرا
اهلا
جزيلا.
وسهلا بحضرتك.
تصبحوا على خير.
حضرتك من
تصبحوا على
اهل
خير.
الله يخليك.
تصبحوا على خير. اتفضل.
بعد اذنك.